Start the meeting. I call a meeting to order. So welcome to meeting number 24 of the House of Commons Standing Committee on Health. Pursuant to the orders of reference of May 26, 2020, the committee will now continue its briefing on the Canadian response to the outbreak of the coronavirus. Pursuant to the motion adopted by the House on May 26, 2020, the committee may continue to sit virtually until Monday, September 21st, 2020, to consider matters related to the COVID-19 pandemic and other matters. In addition to receiving evidence, the committee may now also consider motions which shall be decided by way of a recorded vote. Finally, the House has also authorized our committee to conduct some of our proceedings in camera, specifically for the purpose of considering draft reports or the selection of witnesses. In order to facilitate the work of our interpreters and ensure an orderly meeting, I would like to outline a few rules to follow. So interpretation in this video conference will work very much like in a regular committee meeting. You have the choice at the bottom of your screen of either floor, English, or French. Please speak slowly and clearly and hold your microphone in front of your mouth as directed during the sound check. And let me pause while I switch to the appropriate channel. If you will be speaking in both official languages, please ensure that the interpretation is listed as the language you will speak before you start. For example, if you're going to speak English, please switch to the English feed, then speak. This allows for better sound quality for interpretation. Before speaking, please wait until I recognize you by name, except during questioning of witnesses, when the witnesses may respond appropriately as the questioner requires. When you are ready to speak, click on the microphone icon to activate your mic. Should members need to request the floor outside of their designated time for questions, they should activate their mic and state that they have a point of order. A reminder that all comments by members and witnesses should be addressed through the chair. And should any technical challenges arise, please advise the chair or clerk immediately, and the technical team will work to resolve them. So I also draw your attention to in the upper right-hand corner of your screen, there is a choice between speaker view and gallery view if you're on a PC. If you click to the gallery view with this view, you'll be able to see all of the participants in a grid-like manner, and it will ensure that all video participants can see one another. So I'd now like to welcome our witnesses. Each witness will have 10 minutes for an opening statement, followed by the usual rounds of questions from members. So from the Battered Women's Support Services, we have Angela Marie McDougall, Executive Director. From the Canadian Red Cross, we have Conrad Sauvé, President and Chief Executive Officer. From the Carnegie Community Action Project, we have Fiona York, Project Coordinator and Administrator. From Orange, we have Dr. Homer Tien, President and Chief Executive Officer. And from the region of Peel, we have Nancy Paulsonelli, Interim Chief Administrative Officer. We will begin with Ms. McDougall. Ms. McDougall, please go ahead. You have 10 minutes for your statement. Thank you.
Good afternoon, and thank you, Honorable Chair, and thank you, Madam Clerk, and thank you to all the members of the the House of Commons Committee on Health, Standing Committee on Health. Battered Women's Support Services was formed in 1979. Our mission is to end gender-based violence by changing historic underpinnings of discrimination against women through education, advocacy, and support services to assist all women affected by gender-based violence in our aim toward the elimination of violence, and to work from an intersectional, anti-oppression, feminist, and decolonizing perspective, which is one that promotes equity and liberation for all women. Based in Vancouver, British Columbia, we are a nonpartisan, incorporated nonprofit society and federally registered charity. We are governed by an independent board of directors, and we work in collaboration with similar organizations across Canada and internationally. Over the past 17 years, BWSS has developed a unique expertise, an intersectional approach to the complex and overlapping identities and factors of oppression, disadvantage that impact women and contribute to the subjugation and vulnerability to gender-based violence, including and not limited to domestic and sexualized violence. We work within these areas of focus, which are direct service provision, In 2019, we responded to over 18,000 requests for services through our intake and crisis line, counseling, support groups, legal services and advocacy, employment, Indigenous Women's Program, Black Women's Program, Latin American Women's Program. Training and education. We deliver skill-based training for professionals, systems, and community groups, volunteers, and other individuals.
Pardon me, Ms. McDougall, the interpretation is having trouble. Could you make sure you hold the mic out near your mouth and speak
Sure.
maybe a little slower might help as well.
Okay.
Thank you.
We deliver skill-based training for professionals, systems, and community groups, volunteers, and other individuals. Training and educational workshops are grounded in sound theoretical frameworks that include trauma, sociocultural, and intersectional theory and practice. And our advocacy reach includes legal, institutional, and systemic advocacy to improve the status of women in Canada and the response to gender-based violence. I speak today on behalf of Battered Women Support Services, where our volunteer and staff team continue to provide support services on the front line, supporting survivors of gender-based violence within crisis intervention, counseling, and legal advocacy. Like our counterparts across British Columbia and Canada, the women who access our services are navigating violence against women and gender-based violence, including domestic and sexual violence, poverty, substandard and precarious housing, substance use and ill mental health, sex work and sexual exploitation, as well as compromised immune systems resulting from all of these factors. The COVID-19 pandemic poses very specific challenges for women in our communities. Our services and programs are the vital community-based response positioned to make a difference. The work of organizations include alleviating isolation, as well as providing vital support services that increase women's safety and keep women alive. Our support services span crisis, domestic and sexual violence, and intervention. Last year, I had the privilege of visiting China. And through those contacts and networks, we learned that quarantine was increasing instances of domestic violence. And in those cases, our Chinese counterparts cited COVID-19 pandemic as the major contributing factor in 90% of the cases. This feedback from our counterparts in Beijing, Guangzhou, and Xinjiang were clear that it was important to ensure the continuation of services, to expand or modify services, and to take every action available to advise women of services. In early March, Battered Women Support Services thoughtfully and strongly considered these potential increased rates in violence and worked to get out in front of the problem. We recognize the importance of being nimble and to be creative. So our actions involve scaling up our direct service provision to 24 hours a day, 7 days a week. We included email and text options, as well as a toll-free number. We dedicated our homepage of our website to COVID-19 and violence-specific information, including safety plans, how to help a friend, how to help a neighbor or family member, a listing of shelters and transitional houses in Canada and internationally. And we continue to deploy a comprehensive communications plan utilizing social and mainstream media, advertising, blogs, and email blasts. And we advocated as strong as we could with municipal, provincial, and federal governments for unrestricted funding for supplies, service modification, and increased staffing levels. We sought engagement with provincial and federal health offices to deliver messaging through their platform to advise victims of gender-based violence that their physical safety was more important than social distancing, and to seek out crisis line and tech support. And we continue to utilize alternative measures to conduct outreach, follow-up through remote networks, and to maintain we maintain our physical office for drop-ins and individual in-person appointments. Through these efforts, demand for our services increased upward of 300%, and the calls fell into seven general themes. Women who were out of abusive relationships and were experiencing increased post-trauma reactions and suicidality. Women currently living with abusive partners who were looking for opportunities for their safety and to understand their situation. Co-workers of women who are living with abusive partners where work from home had impacted their ability to assist their co-workers as they had been previously. Family members who wanted to know how they could assist their sister, mother, aunt, cousin, who they knew were in abusive relationships. Neighbors who had previous awareness, who had just become aware of a woman in their apartment building or community and they were looking for options. Professionals who wanted to consult on how they could support their clients under COVID-19. And children and youth who had witnessed their mother's abuse for their entire lifetimes were calling to discuss how they could plan for their safety and their mother's safety and their siblings. The contributing factors we identified through our frontline work over the last 3 months has been economic insecurity and poverty-related stress, the very real impact of the social isolation and quarantine, increased alcohol consumption and the consumption of other substances, licit and illicit, exposure to exploitive relationships, reduced health service availability and access to first responders, reduced contact to schools, neighbors, hairdressers, fear to seek help and or leave the house, instability or temporarily escape abusive relationships and partners, the inability to do that, and exposure to ongoing violence, including violence in the community, such as sexual harassment from landlords. And women were profoundly impacted by the scaling back of services as each service was navigating their own needs in terms of staffing and social distancing, and a profound lack of funding support at the front end of social distancing mandates. In the past, women would contact their support service over the phone while they or their abusive partner was at work or otherwise out of the house. With COVID-19 restrictions, women have fewer opportunities to leave the house and fewer opportunities to call support services such as a shelter. And many shelters, transition houses, are communal living with shared kitchens, laundry, common areas, in some cases shared rooms, and in most cases, shared bathrooms. This kind of environment is not conducive to social distancing, and numerous women that we have placed in transition houses left, citing too much isolation under the lockdown. And we have since engaged the private sector as we continue to work with transition houses and have a floor of rooms in a Vancouver hotel where we have housed and are housing 15 women and 6 children on a temporary basis. Combined with the escalated COVID-19 home quarantine measures, abusive partners are using isolation, coercion, and threats, emotional abuse, economic abuse, abusing children and companion animals, as well as their privilege to fully maximize their power and control to exert violence on their victims with lethal effect. We've experienced in 1 month 11 killings of women. April 1st, a 41-year-old woman was murdered by her 35-year-old partner in Ontario. April 1st, a 33-year-old woman was killed by her domestic partner in Brockville, Ontario. April 2nd, Tracy McKenzie was killed by her partner in Hammonds Plains, Nova Scotia. April 8th, 61-year-old Tina Samardia was assaulted by her husband in Osoyoos, British Columbia, and died a week later from her injuries. April 11th, Julie Rassett, 33-year-old woman, was killed by her partner in Winnipeg, Manitoba. April 17th, a woman was assaulted in Portapique, Nova Scotia, by her long-term common law partner, and she managed to escape and hid in the woods. The man proceeded to murder 22 people, making it the deadliest mass shooting in Canada. The same man had the intentions of killing his ex-wife. Britley Ann Mesereau, 24-year-old, was killed by her common law partner in Calgary on April 27th. May 1st, Tina Tingley MacClair, 43-year-old woman, who was deemed to be called an amazing sister and great mom, was killed by her domestic partner in Hillsborough, New Brunswick. May 4th, Lois Patterson Gartner, 55 years old, and her 13-year-old daughter and their family dog was found dead in a murder-suicide carried out by a man they lived with in rural Strathcona County in Alberta. This number of killings represents a statistical spike in lethal misogynist violence. And it's up to Canada to reinforce the community-based matrix of women and gender-based violence services. For us, it really doesn't matter whether we are talking about COVID-19 pre or now with the lessening of social distancing measures. We continue to do the work. And we know that gender-based violence was already a pandemic. And for every woman that is killed, we know from our frontline work that there are thousands more living in fear. And that concludes my remarks for today. Thank you.
Thank you, Ms. McDougall. We go now to Mr. Sauvé. Mr. Sauvé, please go ahead. 10 minutes, please. Mr. Sauvé, you're on mute.
Oh, ça va être un peu mieux comme ça. Merci.
I think it's going to be better this way. Thank you. Good evening. Thank you for having me here today.
French channel?
Okay. Sorry. Then I'll change halfway through. Bonsoir.
Good evening. Thank you for having me here today. My name is Conrad Sauvé. I'm President and CEO of the Canadian Red Cross. It is an honor to be here today to provide you with an update on our work. And I say an update because it's very significant work, but I believe you have documents that get in depth into the work of the Canadian Red Cross throughout Canada to support our communities, and also supporting the municipal, provincial, and federal governments in the response to COVID-19. I will switch to English now.
So while we've been gradually increasing our responses, I think this is the Red Cross has been increasing its responses to respond to both natural disasters here in Canada. It goes without saying that the size and scope of this response is unprecedented in our history. And we have been responding from the first days of the outbreak by providing support to the Public Health Agency of Canada in helping the some 1,200 Canadian travelers and crews that were quarantined in Trenton and Cornwall in the early days, as well as providing psychosocial support in Japan for the more than 50 Canadians that were in 40 different hospitals in Japan. And it's important to note, and I'm going to come back to this in my presentation, but we did this, we had the ability and the expertise to do this because we have been engaged internationally, thanks to the support of the Canadian government, in providing deploying both cholera and Ebola clinics in the last number of years. So what we did is we re-affected our international health experts to help with the early stages of the response to the quarantine in setting up with the public health agencies the appropriate protocols to ensure that both our staff, our volunteers, and those that we helped could be done so in safety. We are also in partnership with Global Affairs Canada, supporting the shipping and receiving of international donations and protective equipment. C'est sans compter que
And the Red Cross is still offering assistance to vulnerable people here in Canada. We support through different means senior citizens that are vulnerable throughout the country. In Toronto, we've distributed over 5,000 deliveries of groceries to vulnerable people, senior citizens who don't want to move out of their houses. In Ottawa, we have launched a home support program. We have visited over 3,000 senior citizens to make sure that they had everything they needed. And working with Indigenous Services Canada, we've created a virtual operational center in order to offer information and referential support, mental health support to Indigenous communities throughout the country. Right now, we are involved in Montreal, especially in the western part of Montreal, We are offering assistance to senior citizens' homes. We've been doing so for several weeks, and the support of the Red Cross is centered around 3 areas. It's a personal recruitment. We know there's a significant issue related to that, training for personnel and volunteers who go out to these institutions. And finally, we deploy people, support personnel in the different institutions, making sure that the issues are related to reducing infections, disinfection methods in the institutions be adequate. We started by supporting 8 institutions, health institutions, and currently we are at 40, and there is increased need. We are looking to work with the Government of Ontario to deploy similar teams on these issues. And another very significant sector of our operations with Employment and Social Development Canada. We have discussed since the early days of the pandemic of the importance of having protective material and training for the different institutions, but also within the community. So we have a support program to provide PPE in the community and training geared towards 5,000 organizations. We also have a funding program for charity organizations that is not-for-profit organizations that don't have charitable organization status. This program has just been launched.
I think one of the, as you can see, there's a large-scale increase of our operations throughout the country, but I have to note as well that it's not because we have COVID-19 that there's no longer natural disasters. We're active, of course, in many places presently, but again in flooding in Fort McMurray, we're presently there, as well as we're supporting those that have been on following the request of the government of Nova Scotia. We're raising funds for the victims of the terrible tragedy that happened there, and that we were talking about a little earlier. These events are part of a reminder that there are factors that we can plan for in terms of the response, but there's also many risks we cannot plan for. So when we're looking ahead, I think and I'm not going to go into all the types of responses the Red Cross has had, but we're looking ahead in terms of 3 real areas that we want to continue to invest in terms of our responses. One is the focus on vulnerable populations, not just in institutions, but in the community. The work we're doing in Toronto, the work we're doing in Ottawa and going door to door in some communities, we need to map out and understand where vulnerable people are, not just during these events, but also on an ongoing basis. We are also doing friendly calls throughout the country, again, to ensure that people are safe in these communities, but we're seeing that the outreach and what we're doing around Ottawa is essential. We've also, in the case of COVID-19, we've deployed some of our capacity we have purchased, and we have an expertise globally in this area, because this has been funded by Global Affairs Canada to do work internationally. We've deployed field hospitals in many parts of the world, from Nepal to the Philippines to Congo. And as I mentioned earlier, we have managed both Ebola clinics, and we're managing Ebola clinics as well as cholera clinics. This is the first time we've deployed this equipment in Canada. So we've deployed part of our field hospital in Lower Mainland in BC, in Vancouver, that is, I should say, as well as in Montreal. And we have been supporting communities in the north in mobile capacity. And obviously, we need to relook at building up a stronger capacity for national response as well. So we're looking at with the provinces in terms of what are the needs in moving forward. And finally, we have been, of course, increasing our operations throughout the country. Again, we're dealing with a combined issue of the pandemic as well as natural disasters. And this will require that as we increase, we have to think of how do we need to increase our base capacity and what new level of base capacity we need to maintain, again, to support both municipal governments, provincial governments, and the federal government in terms of moving forward. So these are, Mr. Chair, the main parts of my presentation. I'd be happy to answer questions. Thank you.
Thank you, Mr. Sauvé. We go now to Ms. York. Ms. York, please go ahead, 10 minutes.
Thank you for inviting me to be a witness of the House of Commons of Canada Standing Committee on Health. I would like to first acknowledge that I'm speaking to you from the unceded traditional territory of the Coast Salish peoples, including the territories of the Musqueam, the Squamish, and the Tsleil-Waututh nations. My name is Fiona York. I'm the coordinator and administrator of the Carnegie Community Action Project. I've worked in the downtown east side of Vancouver for 10 years. I'm speaking today about those who are homeless, underhoused, or inadequately housed and impacted by poverty and trauma in the downtown east side. Among the most impacted by the current crisis are those who are homeless and living in shelters and SROs, single-room occupancy hotels.
Ms. York,
yes.
Pardon me, maybe you could slow down a little bit. It'll be hard for the interpreters to keep up.
The last City of Vancouver homelessness count showed that there are over 1,200 homeless people in the downtown east side, including 600 unsheltered. This is an undercount. In March, the City of Vancouver declared a homelessness emergency in the City of Vancouver. This is a population that has sustained trauma, personal, systemic, and colonial trauma, poverty and stigma, and the trauma of the HIV epidemic in the 1990s.
Pardon me, Ms. York, you're still a bit too fast for them.
Thank you.
It's quite challenging to listen to one language and convert it and speak it at the same time. So
thank you. Now it is in the midst of one of the worst traumas, the opioid crisis that has claimed almost 1,000 lives in the last 4 years. Added to this is the current pandemic, which both directly and indirectly impacts people in many ways. The CDC explains that COVID-19 most affects older adults, those with pre-existing health conditions, such as those with heart disease, diabetes, asthma, HIV, COPD, and lupus. Housing activists have stated over the years that housing is healthcare. Homeless people already die at a rate that is twice as high as the rest of the population. Diane Yentl, president of the National Low Income Housing Coalition in the US, says, "It has never been so obvious that housing is healthcare, and that we must provide resources to protect people who are homeless from infection and contagion. And we need to prevent others from becoming homeless during a public health emergency. It's really critical, and it's not only a moral imperative that we do so, but it's a public health necessity." Homelessness is currently at an all-time high. Numbers increased by 1 to 2% over the last few years, and homelessness counts are always an undercount. SROs, shelters, and supportive housing went into lockdown early in the pandemic.
Pardon me, I'm sorry, it's still a little fast. People tend to read faster than they speak, and anyway, if you could just slow down. Thank you. Go ahead.
And this has added more homeless who used to shelter with friends and family. One estimate is as high as an additional 400 homelessness due to no guest policies, as well as shelters reduced capacity by up to 50%, meaning even more people in the street. Privately owned SROs are often poorly maintained and have shared washrooms and kitchens, meaning that residents are in close contact and unable to safely self-isolate. Government funding provided meals and cleaning in only 11 SROs, which will be ending soon. Peers and nonprofit groups have been providing meals, supplies, information, and support to people living in tents, on the street, and in adequate housing in the downtown east side. Over 10,000 meals and hygiene kits have been provided by CCAP volunteer efforts. Coming out of the crisis, housing needs to be radically rethought. The lack of housing is devastating and contributes to unsheltered deaths through exposure, violence, substance use, and ill health. Now it is more clear than ever that housing is essential to support the most vulnerable. A demand for hotels from the province and city was answered by the targeted evacuation of Oppenheimer Park Tent City, bypassing those most in need and most at risk of COVID. Taking into account the homeless population, the newly homeless, those in SROs and shelters, close to 9,000 hotel rooms would be needed. 262 were offered to Oppenheimer Park residents, with a reported 638 rooms being provided in total. As borders closed, the illicit drug supply closed up, and drugs became even more lethal. Several overdose prevention sites closed, and OPS use went down from 6,000 per week to 2,000 per week. Overdoses spiked in March, with 8 deaths in 1 week in March. Safe supply measures have helped to address the crisis, but there's no confirmation that it will continue past the pandemic. Sex workers are another group that is disproportionately impacted by COVID-19. Sex workers have been pushed into more unsafe situations, unable to work at home due to no guest policies, and left without an income. Lack of communication and internet contributes to lack of safety and health-related information. Community centers, libraries, daytime drop-in spaces all closed, eliminating access points for information, phones, charging phones, Wi-Fi, and internet, and pushing people into the street. 167 people were counted on one side of one block of Hastings and Main Street. These enforced crowded conditions contribute to lack of social distancing and inability to follow health directives. Community groups have called to open the streets to pedestrians to give those displaced from other spaces somewhere to go, and to close a portion of Hastings streets to non-emergency vehicular traffic. Once again, these displacements from public spaces, services, housing, shelters, and parks displace the most vulnerable and disproportionately Indigenous and those affected by trauma, poverty, and colonialism. Over-policing has been the response to the outdoor crowded conditions. Overuse and misuse of policing as a way to respond and control a community facing a pandemic and unprecedented closures and lack of supports, once again stigmatizing and pathologizing those most in need. The lack of indoor and daytime services has also led to a massive failure of sanitation and washrooms. Hand washing stations and porta potties were placed on Hastings streets and a few other locations. These inadequate facilities led to 2 deaths in 2 weeks, including an infant found passed away in a porta potty. Many peers found themselves out of work when facilities and services shut down. Community members subsist on punitively small incomes, and the small amounts received from peer work are essential supplements. Food security was immediately and continues to be one of the major concerns during the pandemic, with so many daytime facilities and resources closed. Community members and groups responded with donations, in-kind donations, and support for meal distribution programs. The issues of housing, food security, washrooms, and hand washing were no more apparent than the tent city at Oppenheimer Park. There were over 200 tents and 250 people in Oppenheimer Park until May. The provincial announcement on April 25th was welcome news that hotels would be leveraged to safely house those who are homeless, but didn't go nearly far enough and clearly targeted the eyesore of the very visible homelessness in Oppenheimer Park. Once again, hotel units and SROs were stockpiled for those in the park and bypassed others far more in need and at risk. Hotels offered do not address community needs or respond to community input. Restrictive guest policies, no pets or partners, punitive and restrictive rules have made them inaccessible to many vulnerable people. A new tent city has been established in the federally owned parking lot at Crab Park, nearby in the downtown east side, with 40 community members who are unhoused or inadequately housed after Oppenheimer Park, or the many others who are homeless. Park bylaws in Vancouver have lagged behind the provincial requirements that camping be allowed overnight, and street sweeps displace those sleeping in the street on a daily basis. For many, there is simply nowhere to go. My recommendations: call on the federal government to have a national plan and to work with all levels of government to immediately house the homeless by securing empty hotel rooms to house the homeless and underhoused. Secure the hotels now and turn them into permanent housing. House the most vulnerable, not just the most visible. Follow the examples of other cities by triaging and housing those with the highest risk factors, over 65 years old and with underlying health conditions. An open and honest sit-down dialogue about any plan to house the First Peoples in urban environments and what plan is coming to provide homes for on-reserve families with all the basics, including drinking water. To make available homes for the 2,000 and plus sidewalk dwelling persons, especially during this coronavirus, and secure federal funds to open the Balmoral Hotel and Regent Hotel rooms that gives downtown residents a home in a known service providing community. The National Housing Strategy only suggests to reduce homelessness by 50% over 10 years. Instead, we need a federal commitment for the prevention and elimination of homelessness, with expanding federal investment in community-based homelessness responses. Construction of over 300,000 new permanent shelter rate housing units and enhanced rental support for low-income Canadians. Meaningful implementation of the right to housing, immediately purchase or build 3,000 homes that are shelter rate. Develop and fund an aggressive acquisition strategy and work in partnership with provincial, municipal, and nonprofit sectors to purchase properties and assets for shelter rate permanent housing now. Prevent those with deep pockets from sweeping up assets and protect against predatory purchasing of properties. Make reconciliation a reality through respectful engagement with Indigenous peoples, no pipelines on unceded territories, and following the recommendations of Red Women Rising, the UN Declaration on the Rights of Indigenous People, and the Truth and Reconciliation Commission. Given that urban Indigenous people are overrepresented amongst the homeless population, the federal government needs a national strategy addressing urban Indigenous that is led by Indigenous people for Indigenous people. Don't further displace Indigenous people from unceded land by moving people encamped on federal lands or spaces. Let the homeless, mostly Indigenous people, stay at Crab Park where they are safely encamped now and facing an injunction that will displace them into streets and alleys that are more dangerous. Enact the National Protocol and Tent Encampments written by former UN Rapporteur on Adequate Housing, Leilani Farah. Invest in the guidance and direction of peers to ensure the efficacy and appropriateness of any response to homelessness. Work with provinces and territories to provide adequate supplies of personal protective equipment to peers and frontline workers. And finally, ensure access to real safe supply. The opioid crisis remains the biggest health and safety threat in the downtown east side. Thank you very much for your attention.
Thank you very much. We go now to Dr. Tien. Dr. Tien, please go ahead, 10 minutes.
Thank you very much. Good day. I want to thank you for the opportunity to address the Standing Committee on Health today for the briefing on the Canadian response to the outbreak of the coronavirus. So my name is Homer Tien, and I'm the President and CEO of Orange, the provider of air ambulance and critical care transport services to the province of Ontario. I assumed my role in January 2020 after serving as the organization's Chief Medical Officer for 5 years. I'm a surgeon by training, and I was previously medical director for trauma at Toronto Sunnybrook Health Sciences Centre, where I still maintain a practice as a trauma surgeon. I also spent 25 years in the Canadian Armed Forces and retired from the forces as a colonel in 2015 after deploying multiple times to frontline field hospitals in the former Yugoslavia and Afghanistan. So I'm here representing the more than 600 people who are part of the team at Orange. We're the largest air medical and critical care transport organization in Canada, and we conduct approximately 20,000 patient-related transports per year. Orange is an integral part of Ontario's healthcare system, which is based on a hub and spoke model of care. In this model, patients are transported from smaller facilities in rural and remote communities to larger hospitals to receive a higher level of care. And to preserve capacity for the next patient, these same patients are then repatriated back to their home hospital when appropriate and safe to do so. More than 90% of our work is devoted to this type of interfacility transport. To carry out our mission, we have a mix of helicopters, fixed-wing aircraft, and land ambulances staffed by highly skilled paramedics and pilots. And they're supported by aircraft maintenance engineers, communication officers, physicians, and administrative staff. Our operations are based in 11 communities across Ontario, with our head offices in Mississauga. Today, I'd like to share with you the details of our operational response to COVID-19 and provide the committee with some ideas for consideration. Caring for a patient effectively and safely in a mobile environment is challenging. It's about safely and efficiently getting the right patient to the right place with the right asset and crew at the right time. And in the case of air transport, we even need a bit of luck with the weather. COVID-19 has added entirely new complications to this mix. You need to optimize staffing to create surge capacity. You need to reevaluate your personal protective equipment needs in order to reduce risk to staff and patients. And if you think about it, we're operating within the confined space of an aircraft or a land ambulance, a little box, while that patient is coughing or being mechanically ventilated within a couple of inches from the paramedic. As COVID-19 first began to unfold, our organization had three basic objectives: protecting our staff, maintaining service delivery, and planning for a surge. These objectives have informed every decision and every action we have taken. As of May 15th, Orange has transported 531 patients with either a confirmed or suspected COVID-19 diagnosis. Nearly half of these were transported by our critical care land ambulances, about 30% on our fixed-wing aircraft, and about 20% in our helicopters. These were all terribly sick patients. Nearly half of these patients were intubated and being mechanically ventilated. I'm pleased to report that to date, no Orange staff members have tested positive for COVID-19. I'd like to spend some time on one particular aspect of our operation. Orange is the agency responsible for transporting stretcher-bound patients in and out of rural and remote Indigenous communities in the north, many of which are only accessible by air. Our air ambulance crews respond regularly to approximately 30 nursing stations across northern Ontario, performing more than 2,500 transports annually from these communities. If one of these communities suddenly found itself with a number of severe cases of COVID-19, the local healthcare resources would likely become overwhelmed quickly. This situation would lead to a sudden and immediate demand for air medical transport. And in order to protect the other people in the community, those exposed would need to be tested, and those tests would need to be processed quickly at labs in larger centers. But with commercial carriers ceasing or scaling back operations, this becomes much more challenging. Planning for these scenarios has been a central focus at Orange since the crisis began. Orange is a tool for health equity, particularly for rural communities and remote Indigenous communities. We realize that we need to be creative, innovative, and thoughtful about how we use our capabilities in order to provide the needed access to care. Since mid-April, Orange has been coordinating weekly logistical flights to transport samples from northern communities to the labs in the south for processing. To date, more than 2,000 COVID-19 testing samples have been transported via Orange contracted aircraft. This has dramatically increased the speed of processing results, which we all know is critically important to preventing the spread of COVID. In addition, there's been considerable interest in reducing unnecessary travel to hospitals, particularly to those in the south. For the past 2 years, Orange, with its partners, has been supplying point-of-care lab tests to remote Indigenous communities in the Northwest. This has allowed members of these communities to access the appropriate diagnostic care in their communities and avoid unnecessary transport to southern hospitals, where they could be exposed to infection. As well, there's tremendous interest in telemedicine across the entire healthcare sector for the same reason. We've already been offering virtual consultations to Northwest nursing stations in partnership with Thunder Bay Hospital. Last month, Orange began providing additional telemedicine support to the rest of Ontario in partnership with Critical Ontario, the provincial bed-finding agency. Under this arrangement, any physician in any Ontario hospital can reach out to an Orange emergency medicine physician, ICU physician, or pediatrician to receive assistance in managing a patient 24/7. This service is not specific to COVID and can be used for patients with general acute and other critical care needs. We're also working with some of our system partners to look at novel technological solutions. Specifically, we're exploring remotely piloted aircraft systems or drone technologies for the purpose of improving health equity for northern communities. This could involve the delivery of critical medical supplies to nursing stations and the shipping of medical lab samples to health centers. From a surge planning perspective, we're tapping into our most valuable resource, our people. Orange has solicited paramedic volunteers to form a COVID-19 Orange Surge Response Team. 46 Orange paramedics from across the province have volunteered. They can be dropped off at any facility in the province to help with airway management and mechanical ventilation prior to transport. The team's deployment kit has the equipment and medications to be able to function independently and includes the fully equipped airway management bag, a portable mechanical ventilator, monitors, medications, and infusion pumps. None of this could happen without the tireless dedication of our staff, which is why they need whatever support we can provide them during this stressful period. Whenever one of our crews transports a patient with a confirmed case of COVID-19, upon completion of that transport, we automatically put them on an operational pause. The crew is taken offline temporarily in order to facilitate a debrief and a check on their personal needs and their anxiety levels. In doing so, we're hoping to take care of their mental well-being as well as their physical well-being. The Canadian healthcare system is one of the best in the world. Unfortunately, disasters like the COVID-19 pandemic reveal that our rural and remote communities are more vulnerable to disruption in care pathways than our more urban communities. Air ambulance and critical care transport services are nimble, operationally focused organizations. We have the ability to innovate and adapt quickly to unconventional problems that affect access to care and health equity. I would ask leaders and healthcare organizations to just ask us if they have a problem, and we will find a way to help. Thank you to the committee members for inviting me to speak, and I look forward to your questions and discussions later. Thank you.
Thank you, Dr. Chen. We go now to Ms. Pulcinelli. Ms. Pulcinelli, please go ahead. 10 minutes, please.
Thank you, Mr. Chair, for the opportunity to present to the Standing Committee on Health. And good afternoon to members of the committee. My name is Nancy Pulcinelli, and I am the interim CAO for the region of Peel, which I will refer to in my presentation as the region. The region is an upper tier municipal government providing services across the geographic area of Peel in Ontario. Peel is made up of our partner communities, Brampton, Caledon, and Mississauga. Peel is home to approximately 1.5 million people and over 175,000 businesses. The region delivers health, human services, and public works across Peel. COVID has brought unprecedented economic, social, and health impacts for all Canadians, including those living and working in Peel. The social impacts are highest among the most vulnerable and marginalized in our community, and you heard this through the witnesses this evening. This can be the result of social isolation, inadequate housing, loss of jobs, or food insecurity. As I am sure this community has previously heard, these social determinants impact personal health. One of the most challenging social determinants of health in a pandemic is homelessness. There are approximately 4,000 homeless people living in Brampton, Caledon, Mississauga, based on a point-in-time survey done by the region in 2018, so already outdated. When the crisis began, homeless residents in shelters were offered hotels to encourage physically distancing. We acted quickly on that. About 50% of homeless residents now reside in hotels across Peel. We rapidly scaled up testing at the sites where the region and its partners were offering services, with the region's paramedics assisting. The region's public health staff ensured shelters and other services were operating safely. An isolation program provides shelter for those who have risk factors for COVID-19 exposure or have been tested but who can't self-isolate. Those who test positive are provided with a secure, safe place for recovery and support. Let me share one person's story, and it shows how interconnected the challenges can be in a pandemic. For the sake of privacy, I'm changing the name, but this is a true story. Donovan. Donovan is 20 years old, and he is definitely a frontline hero. He works as a cleaner in one of the 28 long-term care homes located in Peel. Now, the region itself operates 5 municipal long-term care homes, but Donovan does not work in one of our homes. Although Donovan works full-time, he finds it difficult to afford housing in Peel. In Peel, nearly 70% of low-income households live in housing that is unaffordable. In fact, while supporting the comfort and care of seniors in a home that is facing chronic COVID outbreaks, Donovan himself was going to sleep at night in a local shelter for young people. Unfortunately, he tested positive for COVID-19. Donovan was immediately connected to our recovery program for the homeless, where he can have the proper care, space, and peace of mind to recover. And of course, Donovan had contact with other shelter staff. There are 13 of these staff now in temporary self-isolation hotel spaces for essential workers. But this is not the end of Donovan's story. The region's recovery program provides more than a self-isolation space. Once someone is introduced to our program, like Donovan, all immediate acute care needs are met. Donovan will see a physician, a nurse practitioner, and have access to 24/7 nursing on-site care. The region will also provide additional health and social services support to provide a path to long-term housing, health, and well-being. It truly is a wraparound service. So for example, Donovan may be connected to primary care, which he can continue using after isolation. As we meet immediate needs in the COVID crisis, we are also addressing other health issues and seeking permanent housing for homeless clients. To do this, the region mobilized nonprofits, community agencies, the region's paramedics and public health experts, and healthcare providers. COVID has called on communities to partner and collaborate on a whole new level. Another example of this collaboration is the Region of Peel Community Response Table. The response table addresses a broad range of needs such as poverty, food insecurity, isolation, domestic violence, racism, and mental health. In the early weeks of the crisis, the region sent a survey to community agencies. We wanted to know what was keeping them up at night. And the survey found that, among other things, about that 57% of those surveyed were facing immediate program closures. Like other organizations, not-for-profits needed support to adapt to the crisis so they can support the community. The region's council approved over $1 million in funding to provide one-time grants to Peel community agencies that support the most vulnerable. In addition to financial support, the Community Response Table helps providers find strength in numbers. It's made up of people from the region's Human and Health Services Department, representatives from our partner communities, and leaders from over 90 community agencies across Peel. The virtual table meets twice per week. And the table has self-organized even further to create task groups that address family violence, the needs of seniors and youth, and systemic discrimination. The pandemic has called on us to locally develop solutions through innovation and partnerships. Beyond the immediate crisis, the Community Response Table can be a continuing force of positive change in Peel through the recovery and beyond. As the communities across Canada have found, seniors in long-term care are also amongst the most vulnerable in the pandemic. As I mentioned, the region operates 5 long-term care homes, and there are 23 additional homes within Peel. To address the needs of these vulnerable residents, we also participate as a region in an integrated response table. This includes Ontario Health Partners, local hospitals, and the region's own public health, long-term care, and paramedic services. This work features a rapid response testing strategy in long-term care homes, in at-risk retirement homes, in shelters, and in group homes. They have done over 8,400 tests for residents and staff beyond what the homes themselves have tested. And mental health. COVID-19 is also amplifying systems pressures for mental health and addiction services. In the pandemic, many programs have been put on hold. Wait lists are growing. This is unsustainable over the longer term. There is and will be a human and community cost. Before the pandemic, the region had created a community safety and well-being action table. So it's this group that is helping to coordinate community partners as we mitigate mental health crisis situations and strengthen system navigation with local services. In closing, municipalities like the region are on the front lines of working to protect our residents, including the vulnerable. Every day, we see opportunities to do more. We're committed to working with both our provincial and federal partners to ensure strong crisis response and gradual, careful recovery. The pandemic is an unprecedented crisis that called for new forms of partnership, and I'm proud to say that the region has done that work. I hope members of this committee will see that the partnerships that municipalities have developed to help the vulnerable in the crisis should be maintained and even expanded. There is opportunity here. As senior governments seek to target human needs, it's these networks that can help to ensure that such investments reach the most in need and support strong community recovery. There is great value and opportunity in having the federal government investing strategically with municipalities. I want to thank you for your time today. We look forward to working with you to support Peel's diverse and growing community. Thank you.
Thank you, Ms. Polsinelli. We go now to our questionings. We'll start with round one. Ms. Vecchio, please go ahead. You have 6 minutes.
Thank you very much, Mr. Chair. I'm just going to start off with the Battered Women's Support Services. Thank you very much for sharing all of the information that
Merci d'avoir participé.
understand that this is an incredible time. We've seen in my community, we've seen about a 45% increase, and you're saying that there's over 300 times those calls, which is incredible. For those women trying to flee, are you finding the majority are single or with families? How would you balance that? What do those numbers look like?
Yeah, thank you for the question very much. And yes, so we're seeing it's about split down the middle. Women that are leaving abusive relationships that are without children, or either their children are in care, or their children are older, or their children are in some other situation. And then women that have children, 1 or up to 6, depending on how large the family is.
Thanks very much, Ms. McDougall. And out of the money that came out, there was $50 million that was provided to shelters and services. Were you one of the recipients of that?
Unfortunately not. That was, I think, a really important investment in funding for shelters and for sexual assault services. Organizations like Battered Women's Support Services and 500 organizations all across the country that do similar services to us, which is to say not specifically sexual violence solely, and not shelter or transitional housing. We fell through the gap there.
Okay, so I think that's exactly where my concerns are, because that is what I'm hearing from many women's organizations across the country, that there is this massive gap. We know that there's only about $10 million left in the constituency fund. Yes. What is it that you find would be one of the solutions? Of course, money is one of the issues, but what are some of the solutions that we can do? Because meantime, we don't know how quickly this money is going to hang out the door on this contingency fund. What are some of the solutions moving forward?
You mean in addition to that $10 million or with that $10 million?
Well, in addition to, or some of the things that you could see that may be a solution, recognizing that funds might be very tight as well. What can we do?
Right. I hope very much that the Canadian government recognize just how important women are in Canada from an intersectional lens, and that would understand that gender-based violence is one of the most pressing issues for us, whether it's sexual harassment, sexual assault, domestic violence. And the range and the ways in gender violence spans our lifetime from the cradle to the grave. It's baked into Canadian society. I do wish that Canada cared enough about that to increase that level of funding, to understand that it matters very much that women feel safe and are able to navigate the world, navigate Canada and all of the aspects of our lived experience. And so that $10 million would double. And I do recognize the role of the private sector, and that we want the private sector to engage also and the larger community also. Government has a role, but this is a social problem and that we all need to be a part of.
Excellent. And, I wasn't thinking about the next question, but you threw a new question to me there as well. One other thing that I think is very, very important is organizations that work with men. Yes. Many of these we know are the perpetrators. Are there community organizations that you're familiar with that received any funding to assist with men that are trying to move forward and in changing ways types of programs?
So interestingly, the first part of my professional life was working with men that were court ordered in what we call batterers treatment. So that is a piece of expertise that I have, and I pay close attention to it. There has not been an investment in that. There has been an investment in bystander intervention. It's good for us to have a healthy level of appreciation for those services. But the biggest message that we can within Canada is to recognize in a broad scale how endemic gender-based violence is, that this should be front and center all the time. It should be part of all COVID-19 advertising that it comes through the federal government. It should be front of mind for everybody right now. And this is a key moment for us. And that the changing the culture involves services and recognizing the social inequality and then the role that men and boys play.
Yeah, thanks very much. And, I like I said, I've heard so much about this across the country. We've seen these increases. We know there's the financial stress. And the biggest issue is that women who are stuck with their abusers because they're not going to work or they're not going to school, so that even that moment of to have a breath is gone for these women. With many of the women that you're speaking to, the ability to leave, what are some of the greatest challenges right now, specifically with COVID-19, on the ability for them to escape their abusers?
So we wanted there to be sufficient advertising and media attention to this issue. Every time we got a call, every time we had a media or did a campaign through social media, our calls increased. And we were not the only one that had that experience. And that was really important, that women found a way. If they knew that services were available, they found a way to reach out. And so we've been able to help women to leave. And I just have to honor their courage. Imagine leaving your home in a pandemic. Leaving an abusive partner during a pandemic. And I can tell you that hundreds of women have done that in British Columbia, and many of those we've been able to support through Battered Women Support Services.
Gosh. Mr. Chair, how many minutes do I have left?
Just under 2 minutes.
Okay, fantastic. Thank you. Just carrying on with that line.
Correction,
yes?
Just under 1 minute.
Okay, not a problem. Then I'm going to switch over to the Peel region, if you don't mind. Thank you so much, Ms. McDougall. And in the Peel region, you've been offering a lot of places for shelters. What are you doing specifically for those domestic abuse cases?
Thank you. I had to find my mute button. Thank you, through the chair. So we have a couple of things that we're doing. Through our community response table, we have a group that is working on domestic violence. And that group is also linked with our community safety and well-being team. And that team does have a group of community agencies that have come together. They are working actively on domestic violence. We are providing, through our agency partnerships, providing on-the-ground supports to anyone that comes forward with those issues. A campaign is also under the works to ensure that we're capturing all of those cases that may exist, or as many of those cases that may exist across the region of Peel. So while Peel is using a funder of some of those community agencies, we truly are working through those community agencies to get to the community, get to those residents that need our help. We're also working with the police, our Peel Regional Police, and they too are part of the community safety and well-being group. So really trying to build a web of supports, because even with this group, it really depends on what their needs are. So we're trying to look at how could we provide the needs based on the individual cases as opposed to a blanket support.
Okay, thank you so much, and thanks. Thank you, Mr. Chair.
Thank you, Ms. Vecchio. We go now to Ms. Sidhu. Ms. Sidhu, please go ahead. 6 minutes.
Thank you, Mr. Chair, and all the witnesses for being here with us. Like many Canadians, I was deeply horrified to read the Canadian Forces report. One of these homes is in my riding. The abusive allegations described in these homes should alarm all of us. I have worked in the healthcare field for 18 years, and I know how important it is to administer compassionate care. We need to do a better job of caring for the people who built this country, who need our help during the crisis. So my first question is for the CEO of the Region of Peel, Nancy Pulcinelli. Nancy, thank you for all the work you are doing. Canadian Armed Forces report identify numerous issues in long-term care. As an operator of 5 long-term care homes, what do you think are the underlying causes of these issues? And what has the region been doing to address the needs of seniors living in region administrated homes? Do you think there's a difference in the quality of care in region administrated homes from private care homes in the Peel region?
Thank you for the question, and through the chair, I'm going to separate the question in two and speak first to what I think are the underlying causes of these issues, and then I will certainly provide some comment to your question about the private homes with respects to municipal homes. The first question is a very important one because, if anything, COVID-19 has exposed various issues in long-term care. So when we look at the issues, certainly we will hear things like staffing ratios, funding, and increased complexity of resident needs that are part of an ongoing discussion about change in long-term care. These are very important and they're absolutely necessary. However, I want to dive a little deeper because there are also cultural issues that are at the core of how we approach long-term care. And these I'd like to highlight a little more for the committee. For a variety of reasons, long-term care has become inherently task-based. We rush, our staff rush to bathing, to feeding, to documenting. It's one resident after another on a very strict schedule with very little time for anything further. The issue is that when we approach long-term care, like a set of tasks, a checklist, if you will, we make the person who's living in that home, we make their needs secondary to completing the task. And in many cases, it becomes fear-based care by the staff member and not the emotional-based care that these seniors deserve. So some thoughts about solutions. We hear a lot about person-centered care. It gets tossed around all the time. But at the core, it does offer solutions. So while we're looking at funding, we also need to look at creating a culture that enables staff to understand and meet the needs of unique people. And those are the people living in the home, their physical and emotional well-being. This is what helps to improve well-being, and it certainly avoids problems before they arise. One example I'll give is a person living with dementia. We know that when people with dementia sometimes wander or they pace endlessly, and this is an issue, both during the outbreak, because that wandering can put them at risk of exposure, and in general, because they can become exhausted and it's a detriment to their own health, increasing their risk of falling. A task-based approach looks at the wandering as a problem. The wandering becomes the problem, and a person may recommend that let's put this individual on an antipsychotic medication, or let's restrain them, or let's allow them to keep on walking all day. A person-centered approach looks at wandering as the symptom and tries to understand why is the person wandering. So we're not fixing the wandering. We're trying to understand why the person's wandering. Through our work at the Region of Peel, we've implemented the innovative butterfly model of care for dementia care. And what we've realized is that people who wander, they wander because they need something. They're looking for something. So they're looking for engagement, affection, security, love. They're also wandering because we put them in environments with long corridors that look endless for them. They just keep walking. So by understanding how we can support them through activity, through conversation, we are creating a home environment, a safe one. So to close this, I'm gonna suggest when we enable true person-centered care, and this isn't easy. It's not about It's not about the surface. It's actually getting deep into the way we work and the way we think as the staff in those long-term care homes. Some things need to be considered. So certainly better staffing ratios. So staff have time to spend getting to know who is in their care, meeting with them, holding their hand, sitting with them. We need regulations that are less focused on documenting the completion of tasks and more focused on measuring emotional care and well-being of those individuals. We need training programs and funding to undertake them so that staff can have a better understanding of complex conditions like dementia and how to understand and meet individual needs.
Thank you. But on a different topic, as you said, currently the region is using hotels to house 51% of shelter residents and at-risk Canadians. Many of these residents include women fleeing domestic violence.
6 minutes.
How will the federal government's investment, $157 million, for organizations that support the homeless help the region and women in particular?
Mm-hmm. So the federal funding provided to the region to date under the Reaching Home program has been critical and essential to the entire regional response. The region led initiatives such as expanding the shelter capacity into vacant hotels, and we have just over 350 homeless individuals in hotel rooms right now. Through this money has supported that, the development and cost of isolation and recovery sites in the program, and it has increased outreach into the community to support safe public health practices. It's all made possible, and this is through federal investment. The region has been able to support funding applications from community agencies as well, so that we can work directly with the homeless population for basic needs like food, cleaning service, enhanced staffing requirements, transportation, as well as supporting those individuals, those women that are in trepidation and are in difficult situations at home. The further funding will allow these regional programs to run till approximately middle of August. And further to that, what we know to be true is the pandemic is not going anywhere soon. And even as we get into recovery, these individuals, whether they are homeless, whether they are those individuals that are in domestic violence situations at home, they will need support, whether it's financial, whether it's food, whether it's general well-being support, far longer than when the emergency is declared over. That's where the funding needs to go.
Thank you.
Merci, Madame Sido. On va maintenant.
Thank you, Madame Sudi. So, Mr. Therio, 6 minutes, Mr. Therio. This evening is Mr. Desile. Mr. Therio is absent. So, the 3/4 of the time will come to Mr. Desile if you are in agreement. So, I would like to thank all the witnesses for coming. Every day we have the opportunity to listen to witnesses such as yourselves. And this is very useful in our reflection. I would just like to remind all of us that this is a week of paramedics. So I like to stress the importance of their frontline work during these exceptionally difficult circumstances with the COVID-19. My first question then is for Mr. Sauvé. Mr. Sauvé, the federal government has invested over $100 million to respond to the new requirements that have come up with the COVID-19 and also to respond to other needs within your organization. So my question, how much money, directly or indirectly, is invested in COVID-19 that's working with your organization? Mr. Sauvé? Well, to answer your question, the full federal support has been invested for COVID-19. A good chunk of the announced amounts are supporting activities that are already ongoing. As I mentioned, there has been an increased amount of money or support offered by the Red Cross at this time to people that are quarantined. And we work through Health Canada. So the money funds those operations. And some of the current operations in the airports. And we have also bought additional equipment to reinforce some of the mobile equipment for the future and to increase our levels of preparation to face emergency situations. We know the Red Cross has been fully involved in emergency operations throughout the country, be there fires, floods. This has to be taken into account in the current pandemic situation. There is increased training and also an increased number of volunteers to support people.
As you see.
I'd just like to say that the Red Cross receives the support from thousands of volunteers whom we train every year and who are available in emergency situations. And most of these volunteers are new retirees, Canadians who have recently retired. It's an additional challenge in regards to COVID-19, where there are some people who are more vulnerable, and we have to recruit among younger individuals for these kinds of operations. So there's a particular context linked to COVID-19. Thank you. In the 3 axes that you identified, there was deployment of staff in centers and on the ground. In regards to Montreal, could you tell us more? Is it staff deployment in long-term care homes? There are 3 pillars to the response. In Montreal, there was especially support for the west part of the island and 3 sectors of response. We're helping them in staff recruitment. We know that there's a major need. So we have teams on the ground to help with recruitment. Also with training of all the staff. We trained around 800 military staff, as well as those who will be going into those centers. And the third is the deployment of specialized teams who work in institutions. Of course, there's the control of the infection within institutions. So we have deployed teams of 2 to 3 people per institution who are there up to 9 days in order to accompany the management team in order to reinforce control and to ensure that there aren't more infections. That sector, which started at 8 institutions, are now up to 40 institutions that we've supported in Montreal, and the demand could go up to 80. And currently, there's also a demand to support institutions in Ontario in the same way. Currently under discussion is to provide training content to the government of Quebec for those who work in institutions, as well as for expert teams that would be deployed there. We're also looking at the northern part of Montreal, where we could help local organizations that are there. What kind of support would you have from the government of Quebec or from the Ministry of Health? What kind of relationship do you have with them? They are very tight links that we have with the government of Quebec. We're in constant contact, no matter what province, with the provincial authorities and with the regional authorities. It's a continuous link. And there's an increased demand for institutions in Quebec. So you're saying, Mr. Desilets, I'm sorry. Thank you, Mr. Chair.
Thank you. Ms. Kwan, go ahead.
Thank you very much, Mr. Chair, and I want to say thank you to all the witnesses for your thoughtful presentation. My first question is for Ms. McDougall. And first off, I want to say thank you tremendously for the work that you do in our community for so many years. And of course, funding was short for your organization even prior to COVID, and with an increase of some 300% in demand for your services, I can imagine the situation and the pressure that's being put on your entire organization there. Now, you touched on just a little bit about the funding aspect. When the government announced their funding for shelters and for transition houses, your organization and others like yours did not qualify for funding. So in light of this, in terms of recommendation, did I hear you correctly to say that you would like to see a $20 million investment from the federal government to support your work at this time?
Yeah, we could easily double that 10 million that has been earmarked for. We could easily double that. You know, and thank you for your comments, Honorable Jenny Kwan, and I'll share them with our team. The challenges that we have right now are not going to stop. I mean, we already had a pandemic. We're moving into the next phase of now lessening social distancing, and there's some sense that things are going to even get more pronounced as we move into this next phase, as women are making decisions. So we're not done by any stretch. And the $10 million that has been earmarked, and the 50 even that was already provided, that's only got us to this point, and it's only going to get us to this point. We need a long-term strategy because the lethality has increased. We haven't seen this many killings of women in such a short period of time in Canada. That should jar many of us, all of us, to recognize for how many women that are killed, there are so many more that are living in fear of lethal violence. And so this is a time for Canada to make a bold step here to redressing and addressing what is clearly one of the most pressing social issues emerging in this health crisis.
And would you say that in terms of the funding, oftentimes what governments do is provide program funding as opposed to core funding, which is really essentially what organizations, I think, like yours need. I wonder if you can address the issue of core funding for me.
Yeah, we need core funding. Well, our services are essential, and especially now under this pandemic, and that has not ceased. We do not have core funding in the same way that health services do. That is required. If we really understand how significant this social problem is, with extraordinary impacts on the social determinants of health, if we really understood that, then we would have core funding. It is mandatory that we move in that direction, and that is a part of the next budget, and that would be a bold step for Canada to make.
Ms. McDougall, can you remember to hold up your mic?
My apologies to the interpreters. I apologize, and also to those listening. Yes. So this is the time is now to act. And core funding is one major thing that Canada can do right now that would make a measurable difference for women victims of violence today.
Building on the issue around the recognition or the need to recognize the social inequality that exists in the community, you mentioned the issue around poverty, the lack of housing, and so on. By way of recommendation related to the social inequality that exists today, what would you recommend?
So Canada has, we are stratified as women within Canada. So the experience of gender violence is overlaid by other aspects. And so Indigenous women are the numbers of violence and deaths and disappearances of Indigenous women are higher for the very reality of their status within Canada, in the way that they are deemed to have a lower status in Canada through the Indian Act and through all the policies and the relationships. So, and then we're stratified along those same lines in terms of women of color, immigrant women of color, migrant women, women with precarious immigration status. And so the social aspects are gendered and are not created equal and don't roll out equally for us as women in Canada. So our policies have to recognize that Canada does have a race and class hierarchy in Canada. It is very important that we acknowledge that reality, and that the services and that our programs and our policies draw on that very clear and obvious reality.
In terms of the need for housing, so this question is for both you, Ms. McDougall, and also for Ms. York. One of the critical issue, of course, is access to safe, secure, affordable housing. We already know that in Vancouver alone, in the 2019 homelessness count, we had over 2,000 people who are homeless in our community. The government's national housing strategy talks about reducing homelessness by 50% within 10 years. That's a long ways to go when we're talking about addressing immediate need for people who are homeless today, and especially for women and families who are trying to escape violence. So to that end, would you say that it would be essential for the government to take this moment and seize it to ensure that there is a significant stimulus package in the budget to address the homelessness crisis, and in the immediate action for the government to actually secure all the hotels, empty hotels that are there right now, and house people?
Fiona, do you want to go?
Sure. I would say 100%. I absolutely agree that there needs to be immediate and very aggressive and very assertive action around housing. I think that since the 70s, there's been a real dire shortage of housing and social housing being built and funding to the CMHC from the federal government. That's resulted in this really dire lack of housing and affordable housing, and especially shelter rate housing, which is what's really needed. So there needs to be a real focus on returning to those levels and building housing for people that are homeless right now, and also people who are underhoused. And so that needs to be done in a very definite and assertive way immediately. And I think with this pandemic, although there's been all this research over and over through the years about how housing reduces other costs in terms of the justice system and the healthcare system, and so many other costs that are impacted in that actually it would be more effective to build the housing. Despite all of that over the years and all of the evidence about how people are impacted by homelessness, it's probably harder to see the impact than currently during this pandemic. Everything is heightened, everything is sped up, and you see it much more clearly. And just in these few months, it's become so much more obvious and so much more apparent that housing is healthcare, and that's really, really needed because we're seeing not only people who are impacted around the pandemic and health issues with COVID-19, but all of those connected harms that relate to the shutdown and the way that we're responding to the pandemic are also impacting people. And those are the things that I touched on, the fact that there's nowhere for people to go outside and people are being displaced, that there's lack of sanitation. All of those other impacts are related to housing as well. So we see this really heightened by the current pandemic. So certainly there needs to be a real change in how we think about housing and homelessness. And with the hotels, what's been offered so far was really targeted, and it was more of an evacuation than really addressing health issues when hotels were offered to people in Oppenheimer Park. So it was certainly a targeting. It wasn't given to those most in need. So we saw younger, able-bodied men in Oppenheimer Park being offered hotels.
Ms. York, could you please wrap?
Sorry?
Wrap up.
What was the question? Wrap up. And the hotels were only offered to about 5% of those in need. So including those who are homeless and including those who are underhoused in SROs and other inadequate housing, the hotels offered addressed about 5% of the need.
Thank you, Ms. Kwan. We go now to Mr. General, starting round 2. Mr. General, please go ahead, 5 minutes.
Thank you, Mr. Chair, and thank you, witnesses, for being here today. Hoping that Mr. Sauvé be able to help shed some light and answer some of our questions when it comes to that shipment that was sent off to China, the 16 tons through support of the Red Cross. We know from internal memos that it took. It was rushed essentially because of the repatriation flight. But from your perspective, would love to hear you replaying the events for us to help maybe connect some dots on our end.
Okay, I'm sorry. Could you be more precise on the question?
Hoping that you can walk me through what happened in the lead up to and after the 16 tons of PPE equipment that was sent to China early on in February.
Well, I think from the early stages, I mean, there was a request for some additional support. This is, I think, what we normally do in terms of, and the Canadian government asked us to facilitate that send off of equipment to China. You're mentioning 16 tons. We're also receiving on the receiving end of gifts as well from China. And to date, we've received 42 tons donated by China in response, and additional 5 tons from Taiwan. And we're expecting another arrival from Taiwan soon, on top of a number of gifts from corporations as well that are not in this. So we manage both sides of this. This has been, we've done this in the past. Mostly Canada has always been shipping aid to the outside. This is one of the first, certainly in my experience, where we've been on the receiving end of gifts as well.
And I know that you're kind of caught in the middle of all this. Do you know that of how much of that 42 tons that you said was shipped back to us from China? How much of that was usable? Was that does it equate to the entire amount, or did we send some of that back again?
No, in terms of the gifts, and we're in that process. We're working very closely with the Public Health Agency of Canada, and all that has been all compliant in terms of our norms. So I'm not aware of anything in terms that was given to us. So it's not useful. We knew beforehand what was being shipped, and it is of quality, and it's validated by the Public Health Agency process. And the way it works is we are on the receiving end, but we're working closely with, again, the Public Health Agency and PSPC procurement to send all that equipment thereon to all the provincial reception centers. So it's done on a priority basis. But to answer your question, everything is, nothing has been shipped back. Everything is of quality.
So help again with this bit at the beginning. This initial. You said that the government had requested you to ship the procure the PPE. How did that happen?
Well, we to do the shipping actually, and I think we did some of the procurement outside. But this is the Chinese Red Cross was on the recipient end of this. This is very common in these types of emergencies. So, and we're used to handling, as I said, not just in this situation, but in previous situations, we've handled the humanitarian gift, and this is what it was at play. So this is a normal practice for us to do that, and we did so.
But sorry, still again, did the Public Health Agency call you up and say, Mr. Sauvé, I need you to send a bunch of PPE to China? Just curious as how this all kind of ended up happening.
No, we have a partnership. We have an ongoing partnership to help with the GAC, with Global Affairs Canada, and we do this on a regular basis. So they activated that agreement in terms of facilitating that. So this is what we do. We've been doing this for some time, and we have the logistical capacity to do that.
But it was sorry to interrupt you, Mr. Sauvé. Only about 15 seconds. But it was approved by the Minister of Health, though. Minister Haidu, these internal documents say that she's the one that ended up approving it. So if it's an existing agreement with GAC, then how does the Minister of Health weigh into this?
Well, I guess there's the GAC is from to go outside. I guess I'm not sure I have the answer to your question, but we have a system to send this off in terms of a previous agreement that we activated. But I mean, I could get some additional answers to you if you want. But again, this is something we have done in the past.
Mr. Chair, do you mind if just allow Mr. Sauvé to perhaps submit some additional documents to the committee to help kind of clear up some of this, what happened back early on with this shipment?
Absolutely. Mr. Sauvé, if you wish to send more information, please send it to the clerk of the committee, and it'll be translated as appropriate and distributed to the whole committee. Thank you.
Absolutely.
We go now, thank you, Mr. General. We go now to Mr. Van Bynen. Mr. Van Bynen, please go ahead. 5 minutes.
Thank you, Mr. Chair, and thank you to all the witnesses that are here today for the important work that you do in protecting our communities and those most vulnerable throughout these difficult times. My first question is for Mr. Sauvé. Last month, the Leger conducted a study of the Canadian Red Cross on the social and the psychological impacts related to COVID-19. And I'm hoping that you can share the study with the committee after the meeting, as I'm very interested in reading it. And I'm sure that my colleagues would be interested in seeing it as well. But in the meantime, could you please share with the committee some of the findings of that study?
Absolutely. I think this is I think the important thing is this is a poll that we're doing every 2 weeks. So we wanted to establish a bit of a baseline because, of course, this is a new reality to have so many people quarantine at home and understanding what they're living through. And what you saw was the first of those polls. I think what we saw out of the first one, of course, was a high level of anxiety in young Canadians, 20-year-olds, about their future, of course. And, you know, it's understandable in terms of they're embarking on life with a lot of uncertainty, and that appeared that way. We are releasing, and I could share this, it's of course in both languages. I can share the first report, and the second report that we released today, we dug a little further in the situation of vulnerabilities of seniors as well. So that's coming out again in people that are living in the community and are feeling the anxieties. This one is just coming out now. But the first one, I think what we highlighted was, again, the concern and maybe not as visible of people starting their life and seeing a lot of uncertainty and feeling anxiety related to that.
Thank you. There is general acceptance that there will be a second wave or even a third wave of this pandemic. And beyond that, with all the global travel that we've been seeing, we'll be faced with these kinds of situations more often. What have you learned so far that you need to consider in building capacity for the likelihood of another pandemic of this scope and scale?
Yeah, thank you. Well, I think certainly the until there's a vaccine, but even if there were a vaccine, there's no guarantee that there won't be another element of pandemic. I think the area where the Red Cross contributes the most is the surge capacity, and we've been building that up to face, of course, natural disasters, again, supporting provinces and municipalities, as well as the federal government. I think the added area here is the whole health side. We've been increasing, I mentioned earlier, I think we've supported 40 institutions in infection control, and we've elaborated a whole program to support community organizations and we're seeing a big need in understanding how do we protect ourselves and live in an environment of COVID. What's the appropriate training, not just in terms of PPE, and there's a lot of talk about PPE, but I think we have to emphasize also training on how to use protective equipment and how to manage social distancing and how do you work in that environment. So this is the area we're growing. And I think the standing capacity, of course, as we're increasing this capacity to support public authorities, what do we need to maintain afterwards in going forward? And finally, I mentioned we've deployed 2 parts of our field hospital. This was all funded for international work. We've deployed that domestically. So looking what kind of standing capacity do we need to maintain in terms of equipment? And I will add one other thing that I didn't mention earlier. Of course, we're going to go into, obviously, at one point, mass vaccination campaigns. How can the Red Cross support that? And how can we make sure that we support the access to vulnerable communities in the North in terms of vaccination?
Dr. Tien, could you answer that question as well?
the support to mass vaccinations in the north, sir?
Not necessarily. In terms of what you've learned so far from this pandemic, and how we should give some thought to building capacity for the likelihood of another pandemic of this scope and scale.
I think, thank you for the clarification. I think, like my colleague from the Red Cross was describing, I think surge capacity is an important aspect of it. And I think part of the challenge for our northern communities, particularly remote Indigenous communities, is getting that surge capacity to those communities in a timely fashion. And I think certainly across Canada, there are multiple air ambulance critical care transport organizations that have dedicated airlift. And I think one of the things that we've learned during this pandemic is that the commercial air carriers aren't immune to major business disruptions. And when they go down, a lot of the supply chain, a lot of the HR resources that are dependent on going by aircraft, diagnostic support, they are all dependent on aircraft, and they're not able to reach the remote north. And so I think the air ambulance services that have dedicated aircraft can play a large role in that and need to be part of that thinking.
Thank you.
Thank you, Mr. Van Bynen.
Thank you.
We go now to Mr. Kitchen, Dr. Kitchen. Dr. Kitchen, please go ahead, 5 minutes.
Thank you, Mr. Chair, and thank you everybody for being here today and your presentations. Dr. Tyne, my wife is going to be impressed that I've had a chance to talk to you today. When I was doing my residency, and she was in a pediatric intensive care nurse at the Hospital of Sick Children and flew with Air Orange just a few years ago, just 37 years ago, that's about it. But with that said, my question, and I appreciate your point. Since I've been out here in Saskatchewan, and I've got to talk with Andrea Robertson, who's the CEO of STARS, and so I'm interested to know what sort of communication you've had with organizations like STARS and Life Flight in the Maritimes, et cetera, on this issue.
In fact, thank you for the question. We actually work very closely with all of them to share best practices. And I think we realize that STARS does a wonderful job in what they do, LifeFlight as well. And I think, as we know, it's about sharing best practices. We, in fact, set up a Canadian organization, the Transport Medicine Association, that we meet annually to share best practices, and we have a lot of collaboration back and forth. We actually have an academic symposium where we have a supplement to publish some of our learnings, including some of our stuff on what we learned about the COVID-19 pandemic and how do we conduct air ambulance transports in that environment. So I guess to answer your question succinctly, we collaborate a lot with them and appreciate that relationship.
Are they experiencing similar challenges as you are?
My understanding, and this was based about, I think, from a conversation maybe a month ago, I don't think they've seen the same spike in volumes, and lucky for them, I think Ontario, unfortunately, has more COVID patients and more ICU patients. So because we do the transports in between to access critical care capacity, we've actually done quite a few, and I don't think they've had as many in Alberta or in Saskatchewan, thankfully.
Thank you. I was intrigued by your comment on your surge team, and in particular your 46 paramedics, volunteers, and obviously the challenges that you have with them in providing, making sure, as you indicated, in confined spaces to make certain that they're protected, et cetera, and the airway management. Is that something that you're actually as well putting out there to these other air ambulances across the country?
I think we had the opportunity to present that, but to be honest, I think in the time of COVID, it's been more about communicating the capability to our northern partners, and certainly I think our remote Indigenous communities are particularly interested in it. I've spent a fair bit of time trying to communicate that capability because unfortunately, if there is a surge in the northern Indigenous communities or any rural community for that matter, we can't predict where it will come, and we can't augment all of the hospitals all at once for an indefinite period of time. So from my point of view, I think the surge team is the way to go in terms of if one hospital or one area has a regional surge in COVID cases, because we have air assets, we can transport these people quickly to augment their hospital staff while we arrange with the provincial government transport to disperse the patients across the system.
And that sounds excellent, especially when we have hospitals in rural parts where they're shutting down their emerges in order to prepare for those surges, et cetera. So I appreciate that. Ms. McDougall, we've heard a lot of talk about from everybody on the big cities, Vancouver, Montreal, Ottawa, Toronto. But I come from rural Canada. And so rural Canada, we are having a lot of the same issues that you're having. And, in my community, Vision Counseling and Support Center.
Donc, des centres.
Oxbow. They're being challenged in order to get the issues and things like, for example, I had the opportunity to talk to them in the last couple of days, and they mentioned things that they're looking at, in particular, appropriate data management systems. And my understanding is to purchase such a thing is $25,000 to start, and then $6,000 a year just to maintain it. And in rural communities where we have towns that are hours away from bigger centers, where you're seeing where people aren't able to escape because there are no jobs for people to work, and are these abusive partnerships are there, where you've got spouses that are contained, you've got youth that are in there. There's no transition house to go. There's no bus services for them to actually get those buses to other areas. I'm wondering if you could comment on that from a rural point of view.
Mm-hmm. Thank you so much for the question and for the comments and for setting out the context of rural Canada and rural Saskatchewan. And I have so much love for Saskatchewan, a beautiful part of the world. Yes, everything you said is correct. For women in rural communities, everything that we've talked about is compounded. As it happens, our crisis line, we've been receiving calls from rural Canada where women and young people are in the homes and are wondering, and there happens to be more guns as well because of hunting and lifestyle around sport, the kind of outdoor sports. And so the lethality factors are compounded. And of the deaths that I talked about at my remarks, many of the women were living in rural Canada. And so absolutely, rural Canada faces so many more challenges. And we are so far away from addressing those needs. So everything you said about transportation, about having the support services available, but we can go a long way by using technology. And we felt so strongly about the importance of having internet access for women, for everybody, all over British Columbia, all over the provinces in Canada. And so that rural women that are in rural communities can be able to reach out and connect remotely to services such as ours and others that may be in Saskatchewan, maybe somewhere else, in order to get support and to make a plan. Lots can be done through the internet. And if we can build that kind of capacity, we'll go a long way to supporting women that are extremely and profoundly isolated in the way that you just described.
Okay, Mr. Chair, I didn't hear you. I assume you gave me the go-ahead to start. I want to thank you folks for all being here today. Mr. Sauvé, MP Genero touched on the international aid topic for a little bit there. I think many of us can agree that international aid is important, and especially during a health crisis like this. I'm interested in your thoughts and your views on why Canada ought to provide equipment and supplies to other countries when they are experiencing health emergencies. It helps that country, it helps Canada, it helps the world. And I'm interested in your thoughts on why we do that and whether we should continue to do that.
Well, thank you for the question. I think the first of all, we need to maintain an expertise. Of course, the best way to prevent pandemics is to help address the early onset and to provide all the support. But also, if we're going to fight this pandemic, we need to help countries eradicate it as well, not just in Canada, but the rest. But I started off a bit of my presentation and we've been providing a lot of support to Canadian institutions, to working with FAC at the beginning. And a lot of that expertise we brought from the fact that we've been deploying Canadian medical personnel and running both cholera and Ebola clinics around the world. This is where we gained a lot of expertise, and we maintained that. So, and I think it's important to maintain our expertise in times where we don't have a lot of things, a lot of major issues in Canada, maintain that by helping others. We're also in a time where we have organized direct conferences for all for Canadian healthcare experts in real time, webinars with both Chinese authorities, medical authorities on the ground, doctors, with South Korean medical expertise and doctors on the ground, as well as with Italian personnel as well. And that's been hugely successful in getting in real time what the experience is there and how they've addressed certain issues. So I think we need the same thing. And of course, when you're in the middle of something, you need to concentrate on dealing with it domestically. But hopefully, as we come out of this, we need to continue to share what we've learned and to learn how others have done the same thing. So again, I know we've received some gifts. This is the first time actually we've received, in my knowledge, the Canadian Red Cross we've been managing the stockpile to help others, and we've been doing that quite generously. This is the first time we're receiving also help from others in this time of need.
Mr. Fisher, you're on mute.
Sticking with you, Mr. Sauvé. Thank you, Mr. Chair. You talked about the first days of the outbreak and that you've been responding. You've been on the ground since the first days, and you talked about capacity. It seems to me that Canadian Red Cross is always there, or they're everywhere. I'm interested in you talking about building a stronger capacity. You said that in your opening remarks. Were you talking about building a stronger capacity for COVID, for phase 1, phase 2, phase 3, whatever? Or are you just talking about Canadian Red Cross wanting to build a stronger capacity? And also maybe you could just touch on what those early days looked like. And are you talking early days domestically here in Canada, or were you paying strict attention to what was going on with the pandemic or the epidemic in those days?
No, well, just to start off with your second question, early days was really the immediate response to, we all know the Canadians that were caught in the cruise ships and that needed to be brought home and be treated in the most humane, possibly at the same time being quarantined. So that's where we provided immediate assistance, as well as those that were in Japan. So we did that. So we're talking about direct operations. I think the key thing in terms of when we talk about surge capacity, the Red Cross, as you say, is present everywhere, and everybody congratulates us for that. What you don't see is the amount of training we do to make sure that people are ready, that we have volunteers ready, that we have pre-positioned materials ready. And we've been talking the last few years about increasing that base capacity to deal with natural disasters. I think we've helped some 260,000 Canadians in the last 4 years displaced by fires, floods, and so on. And now we have an additional component, which is a pandemic, which requires a little more specialized surge, a little more capacity in terms of infection. So we want to take stock a little bit with public authorities on what the expectation is for the Red Cross to support them, both at the municipal, provincial, of course, and national level. And then how do we need to increase that base capacity? What kind of equipment we need to restock? And when I talk about equipment, and that's why I've talked about our partnership with, of course, in supporting provincial health authorities, what has worked, what is needed for a second wave, what is helpful. Because in a first reaction, we tend to throw everything what we have at something. After that, we can sort of say, okay, well, what is it exactly we need to restock on? And I was talking about the North a little bit in terms of we have 80-bed full hospitals. We've deployed parts of those. Again, this expertise was developed on the international side, and we are very strong. But this expertise was used efficiently in Canada. But when we look at the north, we look at smaller mobile capacity, and we've got a lot of requests from First Nation communities, of course, to deploy equipment and support them. So I think we're taking stock of the fact that we have to stop treating these surge events as exceptional. We need a standing capacity that's a little more elevated to support all these needs.
Yes. Merci, Monsieur Fisher.
Thank you.
So, thank you, Mr. Fisher. Monsieur Desilets, can you go ahead? 2.5 minutes. Yes, Mr. Sauvé, I just want to come back to what you said in relation to the $100 million injected by the Canadian federal government. In your opinion, we are hearing that these sums are not getting to Quebec quickly enough and to other places from the Red Cross. Is it true? What reasonable time frame should we have for these monies to get there? It seems they can't hear. Were you asking me if there are delays in injecting funds to bring our operations to Quebec? Yes, that's what we hear from the subsidized agencies. Is it true, in your opinion? And as far as you're concerned, what would be a reasonable time frame for these monies to be transmitted? Well, I believe there is a broader issue in terms of emergency funding. In an emergency situation, we should be able to quickly access funds. In the Red Cross, we had some reserve funding to get going quickly. We received support from the government. We are looking at these issues. I don't think our operations in Quebec have really been slowed down in Quebec. When we were asked, we ramped up our operations. So these are some of the instructions in relating to the monies we received from the federal government. We had to look into not only the current needs, but to have some reserve funding that would allow us to ramp up our activities. So we did receive support. I don't think there were any delays as such in real time within the Red Cross. I'll give you an example. The CEO of United Way in Montreal, at the start of the pandemic, 2 months later, he did not receive even $1. I'm not sure if that situation has been resolved. Are these reasonable delays? I do believe there is a broader question to see how we can go beyond in these emergency situations. I think it's a true situation. We are discussing with public security provinces to accelerate access to funding. But we do have some reserve funding to meet some of these emergency needs. It's always difficult to get funding going out quickly, and given the scale of the pandemic, it's even harder. But I won't say our operations have really been slowed down. A quick question, just and you give some aid. Thank you, sir. That's okay, Mr. Chair.
Kwan, we go to you for 2.5 minutes, please.
Thank you very much, Mr. Chair. On the issue around violence against women, we know that in the face of the pandemic, the numbers are going up. Even in the best of times, the situation is bad. In my community of Vancouver East, and particularly in the downtown east side, sex workers are particularly vulnerable. And we're now even seeing people enter into sex work for the first time. And much of this, of course, is tied into economic insecurity. The fact is that the government chose not to go forward with a universal direct payment, and people in dire straits, people who are in domestic violence situations, don't have the economic support to find alternatives. So I wonder, Ms. McDougall, would you support for the government to initiate the universal direct payment for all during the pandemic, and I would argue post-pandemic?
Mm-hmm. Yes, we have definitely made that case. I'm on record. I've sent a letter to our Prime Minister and to our province and to the various ministries within the federal government making that request for the reasons that you've articulated here, in recognition that there is already a lot of gender inequality that is economic inequality, and that the pandemic has ground down in very specific gendered ways for women, and that precarity around immigration, desperate times call for desperate measures, and so for many women, there is a number of different challenges that they have with respect to feeding themselves, keeping a roof over their heads, and that includes women that are involved in sex work, and women who may be sexually exploited during this time through income inequality and insecurity as well.
One of the issues that has been raised in recognition of essential workers, people who are in community services, the grocery stores and so on, is this courage pay. And I'm hearing mixed stories about who's getting the courage pay and who may not be getting it. I wonder if you can comment on that and whether or not people, for example, in your organization, the Battered Women's Support Services and others like yours, are they getting the courage pay?
So that is an interesting concept, isn't it? And yes, our frontline workers would be eligible for it. And we've already we already did that for ourselves in recognition that, that we on a wing and a prayer, we recognize in going 24 hours that we're going to need to have all clean hands on deck. And so we did institute a number of measures in terms of ensuring that our frontline staff had we're receiving, which could fall under the banner of courage pay, because of how essential this work was and how it was not recognized. One of the things that I think will be really important for, if I may please suggest, for the Standing Committee on Health, is to really examine the gendered impacts and how that the impacts for women have been profound and unique and differential. And so this is a critical important. And I would also ask our witnesses to also consider the gendered impacts in all of their areas right now, in their areas of focus and influence, and the ways in which women have been profoundly affected under COVID-19. And because we have a number of inequalities still, and a lack of equity in Canada, it really matters that right now we are shining a light on the gendered impacts, and that we're seeking to redress these impacts, which goes to the point around pay and courage pay and income equality.
Thank you, Ms. Kwan. We go now to Mr. Weber. We're starting round 3. Mr. Weber, please go ahead. 5 minutes.
Thank you, Mr. Chair, and thank you to everyone here today. My first question to Mr. Conrad Sauvé. Mr. Sauvé, you didn't talk about this today in your presentation, but I did get this information from the Library of Parliament, and they indicate that at the request of the Public Health Agency of Canada, the Canadian Red Cross is providing services to Canadians returning to Canada in Vancouver, Calgary, Toronto, and Montreal. Services offered include information services, safety and well-being support, and also meal delivery. Can you just maybe elaborate a bit on that and tell me why you are delivering meals to people traveling abroad and coming home?
Well, I think it's the extension of what we've been doing I've talked about Trenton in terms of the returning Canadians on the cruise ship lines. We've extended that to support the Public Health Agency. People who arrive here who don't have a clear plan for their quarantine, we're supporting them in that quarantine period. And that's what this is about. So I don't have the exact number, but that's what we're doing basically. So it's a prolonged, it's a continuation of what we've been doing in this case to make sure that these people are being quarantined for the full period.
I see. It's the individuals who were perhaps in tight spots, such as cruise ships and such, where there was quite a appearance of COVID, and the people in distress basically coming back to Canada and being put into these bases, these Canadian Forces bases.
The Canadian bases was the cruise ship plan, and there was a number of them. That's what we did. There was about 1,200, and then following that, we're supporting I don't have the exact number of airports. I think it's 8 of them You know, anybody who comes back, Canadian come back who does not have a clear plan, we will support that quarantine period as close as possible to the airport to avoid that they travel within the country.
So you would actually provide then quarantine spaces in these 4 cities to accommodate individuals who do not have any other way to quarantine or self-isolate for 14 days. Okay.
That's right.
And it's where you feed them as well and provide all the essential services. Okay. Thank you for that. I also wanted to ask you a question about the deployment of your mobile field hospitals. You mentioned that you had 2 field hospitals, one that went up in Vancouver and one in Montreal. First of all, how many field hospitals do you have at the Canadian Red Cross at your disposal? And who decides where the deployment of these field hospitals are to go?
Right. Well, so we have, I don't have the exact numbers. We probably have 2. We already have 2 80-bed field hospitals. We have a number of mobile units as well. These deployments have been done at the request of the health authorities in the province. In the case, BC early on asked, and we had done exercises. We had looked at the possibility that this could be used, and the sub-regional health authority in Montreal West asked the same thing. Yeah. And we have capacity on standby with the Canadian government as well for deploying in the north.
Okay. The reason I ask is in my riding, the Calgary Foothills Hospital in Calgary Confederation, they actually set up a temporary tent, quite a large structure to accommodate the COVID patients there to keep them away from the general population of the hospital. And that was at quite the cost. If the Alberta Health Services would have asked the Red Cross, you would have then deployed one there as well. Is that the case?
Yes, but I think what I was talking about earlier, I think when we look at, we need to go back and look at, you know, what was the actual use of all these equipments? What's the best way to do this? We couldn't have answered all the requests because there's a number of tented structures that happen everywhere. And we responded in the way we could with what we had. But that's a little bit of the point where I think we need to go back with the health authorities and look again, what have they been required? What's useful? And what can we keep in stock that you know will be useful for these situations.
Great. Well, thank you for that. Dr. Tien, quick question here. First of all, thank you for your service in the armed forces. We can't thank veterans enough for their service. You talked a bit about point of care and sending lab tests to remote communities and doing lab tests and such. And you talked a bit about sending deployment tips, or deployment kits such as ventilators and personal protective equipment up to remote communities to, I guess, temporarily ventilate patients up there and then send them back. With respect to perhaps deploying a kit there on a permanent basis, such as to leave the patient in their community and to provide care there, is that an option, or do these patients need to be sent back to larger hospitals, which again would cause risk for others in these larger cities?
Thank you for the question, and I think it's important to realize that some of the communities that we're talking about for the surge, and it wouldn't be just the equipment that would go; it would be with the critical care paramedic who would go with the kit. They actually have very, very little infrastructure there. So at some of these remote Indigenous communities in Northern Ontario, it's a nursing station with no inpatient facility. So the model of care there would be to evacuate them as quickly as possible. But if there were, say, 6 or 7 community members and they were waiting for the airlift out, at least we could leave some people there to keep those patients alive awaiting transport.
I see.
Thank you, Mr. Weber. We go now to Dr. Pawlowski. Dr. Pawlowski, please go ahead. 5 minutes.
Well, I have to thank Mr. Weber because he set me up nicely for my question. So to Dr. Tien as well, and I'm kind of lobbing him one because I know the answer to this question because we've talked about it before. But let me set it up, and already Mr. Weber has kind of set it up. already the problem in a lot of these northern Indigenous communities is there is no infrastructure. Basically, the solution to any real medical problem, if anyone's really sick, is to fly them out. And so to call Dr. Chen in Orange and say, come and help us, we need to get somebody out of the community. And now we also know that if COVID gets into those northern Indigenous communities, it's likely to be bad. It's likely to spread quickly given the lack of housing, the lack of water supplies, given the fact that for some reason they seem unusually susceptible to respiratory tract infections like influenza H1N1 hit those communities really hard. So if we were faced with multiple people all very sick at the same time, does Orange have the capacity to get a lot of people out of there quickly, or do you have too limited airplane capacity in order to move a lot of people quickly? So I know you do have a solution, so I'd like to hear your solution.
Yes. Thank you, sir. So obviously we have some capacity, but in planning for the COVID surge, we have to think beyond the normal influenza season of 1 or 2 patients or even 3 patients that need immediate evacuation because they're in severe respiratory distress. So one of our surge plans, apart from having the personnel, the critical care paramedics, is that we've liaised with the Canadian Armed Forces to look at, could there be a request for assistance, an RFA, where we could leverage one of their military transport propellered aircraft, the Hercules, or even a C-17, one of the 4-engine jets, drive our ambulances on board and bring the surge response team with the land ambulance capability to these communities. The idea would be that they could drive to the nursing station, load the patients on, provide critical care, ventilator care, fly back to the regional hospital, drive to the hospital, and keep making runs. And because they have such a large capacity, we would be able to move a larger number of patients more quickly. So we did the initial fit test with our ambulances on the military airframes. They have to work out certain things like very technical things like where the ambulance needs to sit in terms of the axle of the aircraft, the load and the weight, and what happens to the any air circulation in the ambulance. Does it actually leave the ambulance and enter the aircraft? So they're working out some of those details from a doctrinal point of view. But we've actually already done the fit test. And I think hopefully there is no second wave, but if there is a second wave that requires this, hopefully we'll have this capability on board to offload some of these communities rapidly.
The second thing was, and again, we've talked about this, I know a lot of those northern Indigenous communities were interested in the idea of a field hospital, and the Red Cross has already discussed that with us. Now, we talked about it, and you also suggested maybe the idea of a minimal treatment center. Could you explain a little bit what a minimal treatment center is and the rationale for using those?
I think it's very difficult for these communities to have a field hospital, as at least I would know it from the military, where we'd have an operating room, ventilators, and ICU capacity for any prolonged period of time. These communities, even the largest of them, have maybe 3,000 people, 5,000 people, and it'd be hard to sustain field operations for a prolonged period of time. So I think having a fairly minimal setup of some sections of tentage where they can provide primary level care for patients with COVID so that they're separate from the rest of the community, and so basic nursing care, but with the idea that if they were developing respiratory distress, they'd be evacuated out quickly, but those who were relatively mild could be kept in the community, and then once COVID negative could be returned back to their homes.
Do I still have time, Mr. Chair?
You're right at 7 seconds.
I can't talk that quickly.
Okay, well, thank you. And we go now to Ms. Jansen. Ms. Jansen, please go ahead, 5 minutes.
Yes, thank you very much. First of all, I wanted to quickly say to Ms. Polsinelli, thank you so much for your fantastic explanation of the difference between task-based care and person-centered care. That was very much appreciated, probably the best I've heard. So, my question is actually for Mr. Tan. Have you seen the NavCan press release of May the 5th that announces overnight air navigation services suspended at 18 airports across the country?
I did hear about that, yes.
Would closures of this type affect your organization at all, should they happen in your region?
To date, my air ops people have said that not so much.
So it would be no problem for you if ambulances could not stop at night into airports?
Well, it would, but to my knowledge, there hasn't been because of that, there hasn't been a cessation of service, to my knowledge, in Ontario.
Okay, so
but
it would affect you though if they had that kind of a closure.
Absolutely, we're completely dependent on airports. So if an airport did shut down because of any reason, and there's many different reasons for shutdown besides that reason, we would be affected. It would deeply affect our operations, particularly in the north.
Right, exactly. So 11 of the airport suspensions, turns out that they're all centered in a single province. I mean, imagine that, 11 of those airports and in one province. And unfortunately, they are all planned for my province of BC, which I can imagine is significantly going to affect our air ambulance service here. What would you say to our people here that are having to deal with these closures at night in 11 of our airports? And I'm imagining that these would be airports that service rural areas.
I think airports fall within the jurisdiction of an essential service, especially in the pandemic. And not knowing the communities, I can't speak to the impact on the communities, but if they were rural and remote, and generally they tend to be rural and remote, there'd be a tremendous impact on their ability to access critical care services. So they wouldn't be able to get out of the community, and if they needed any critical supplies or HR resources, they wouldn't be able to get into their community. So I would think it would have a tremendous effect.
Yeah, exactly. I was looking at the list and I noticed that there is absolutely no suspensions in either Ontario or Quebec. And I was just wondering, are you at all concerned that if they would announce further expansions of these closures for your province there?
I would be, absolutely. There's been issues from a variety of reasons, and we're very concerned about because of airports and their ability to function, because we are completely dependent on them, especially for our fixed wing aircraft.
So I understand that you are short on PPE. I think I saw that in one of the presentations here. And today I had asked the Minister of Public Services and Procurement how exactly organizations like, for instance, fire halls, homeless shelters, and paramedics and ambulance services are supposed to ensure they can access PPE when shortages just continue to be really a very serious problem, because we're seeing that here locally. She assured me that their government is doing an amazing job sourcing PPE both here and abroad, but have you seen an increase in PPE availability?
So we've actually, when I said we were short on PPE, I think that was in the very beginning of the pandemic. And so we've been actively working with the Provincial Ministry of Health, and we've also been looking at reusable PPE as well as a backup. And so our current state is actually, with our current run rate, we're not short of PPE.
Okay, so you're not expecting that you would have to start to ration PPE at this point in time because you're actually able to reuse. Is that the case?
We have a reusable stock. So when we were short, we were looking for washable gowns, washable face masks, washable masks. And then the normal source of PPE that we get through the government as well. And so we pursued all avenues.
Right. Okay. Well, maybe I can go to Ms. Polsinelli. I had noticed that at least 3 of our witnesses today are all talking about seeking PPE donations from the community. And I know that my local battered women's shelter and homeless shelter and the fire hall, they're all seeking PPE. And with the current directive from Dr. Tam for all Canadians to wear masks in public, are you concerned that those types of donations will dry up going forward, and you may have to either ration PPE or curtail services?
Thank you for the question through the chair. At this point, it's not, we have enough supply of PPE. So we're looking at it from two perspectives. We do accept donations today, and we look to continuing to do that. Oftentimes the donations are for particular agencies, so we will reroute donations to those agencies, or through our community response table. We do have agencies that continue to be concerned about their PPE supply. They don't have the amount, the money, or storage capacity. So we are trying to support from that perspective. Internally, we do have frontline staff, whether it be in our long-term care homes as well as in our paramedic services, and those staff that work in shelters. We have, similar to Dr. Tan, in the early days of the COVID, we had lots of concern. There's also been lots of learning. So what we've done is we've worked very closely with Ontario Health. We are using an equitable distribution methodology to get PPE out. We've also brought together, so for the entire region, brought together a central logistics division so that we can really make sure that we always have that threshold supply. And again, working with Ontario Health, we've also worked very closely with our hospital partners in Peel so that there's always at least 3 weeks supply in our in storage and inventory, so that doesn't pose a problem for us. And that's how we're looking at it today.
Thank you, Ms. Jansen. I'll go now to Mr. Kellaway. Mr. Kellaway, please go ahead, 5 minutes.
Thank you, Mr. Chair, and hello, colleagues, and to the witnesses. A sincere appreciation for the work you do on a daily basis. I've had the opportunity to study leadership and teach it at the University of Calgary for a couple of years, and often we would hit a chapter called Servant Leadership. And you folks, every one of you and your colleagues are the embodiment of that. So thank you much for your servant leadership in everything that you do. I have two questions. First one is to Mr. Sauvé from the Red Cross. In my riding of Cape Breton Canso, I've often hear from First Nations chiefs and leaders, Mi'kmaq leaders and chiefs, what more can be done from a federal government perspective to support community development in First Nations across Cape Breton and northeastern Nova Scotia. And I know you folks are in partnership with Indigenous Services Canada and are working with Indigenous communities across the country to provide support to communities in need. So I'm interested to learn more about the work you're doing. If we can unpack that a bit and go a little deeper in terms of the work you're doing in First Nations communities, and how many communities have you been able to help across the country during COVID? Thank you.
Thank you. I think we've set up actually a virtual assistance program. I'm going to go back to a little bit what my colleague from Orange was talking about as well. And it is, we have modular capacity, so small capacity to deploy, not full field hospitals, but a smaller capacity. But we've been getting a lot of requests around providing additional equipment as well, so that communities that are isolated could set up quarantine structures. And that's not medical stuff, but it's also basic blankets, cots, and so on. But I think one of the biggest areas that we're looking at is is training and advice, because there was a big concern, of course, at the beginning of COVID. We got a lot of requests to deploy full equipment in case something happened. And where we're getting a lot of questions is, around to deploy expertise, people that have experience in helping the community set up, accompanying the community in terms of how how to set up properly, and ongoing training. So we're seeing a big area of ongoing training. We have also, just to refer to a previous question, for all organizations, we have purchased, with the support of the federal government, some PPE equipment for community-based organizations, and First Nations fall into that as well, in terms of kits that are available for the next few months. And we've got enough available kits for 5,000 organizations, and we want to increase that quite a bit. So we've set up a 24-hour call center for First Nation communities in 5 different languages, and answering basically all the requests and all the type of support we can do and directing them in the right place. But again, I think ongoing, it's there's a lot of effort in terms of training and ongoing training and building local capacity, because in any situation, like an emergency, like in, the first response happens locally. We need to send in specialized teams after that, but how can we build local capacity?
So when you speak of training, can you give us a little more detail as to specifically what areas of training? I'm just very curious about that.
Well, I think the biggest area that has increased in following this response is what we've built an expertise in infection training and control internationally that we've brought domestically. So we're getting a lot of requests from institutions, from organizations to send an expert in. There's a lot of stuff available online. There's a lot of material, but to accompany them and understand what are the activities they're organizing and how they can do that safely for their personnel, their volunteers, and themselves. This is where we're getting the biggest requests.
I'm really glad to see that you're looking at developing capacity in the communities in collaboration with First Nations communities. That's considering that we're perhaps looking at a second and third wave, and so I'm appreciative of that. Mr. Chair, how much time do I have left?
You have 40 seconds left.
Okay, I have a quick question from Mrs. York. Given that those experiencing homelessness don't have access to the same amenities such as internet and cable, how do we ensure that they know how to recognize the signs and the symptoms of COVID-19? How can we raise awareness and reach those experiencing homelessness in other ways? And perhaps looking at this from an urban and a rural lens. Urban, you see, it oftentimes it's visible. In rural, it's not, but it's still very much prevalent.
I would answer that by saying in a number of ways. So early on, there was a deployment of peers, and I think that peers are a really effective and good way to provide information. So a lot of that was done through direct one-to-one information sharing and also posters, because we often see that even prior to the pandemic that doing things word of mouth and through posters in the community is a really effective way to communicate. Also, there have been solicitations and donations of phones to people through companies and through community groups, and so that's been really great. That was more recently. There's also been advocacy around Wi-Fi, opening up Wi-Fi and making that available to people in the community. So having even just a downtown East Side community-wide Wi-Fi, and I think those things could be replicated to some degree in smaller communities as well. I think that peers always have a really important place and are really in best position in many ways to speak to their peers and have the lived experience to do that effectively, and making use of non-digital forms of communication. So like posters and handouts is really great. Having that conversation one-on-one, and then also advocating for the digital tools and resources as well.
Thank you.
Merci, Monsieur Calloway. Maintenant, c'est...
Now, Mr. Desilets, go ahead. You have 2.5 minutes. Thank you, Mr. Chair. My question is for Ms. Paulsonelli. And it might not quite be in your field of expertise, but I'd like to know what you think of the crisis, the way it's going on in Quebec. I'd like to know what you think of that. What do you think of what's going on over there? How do you see it?
Through the chair, are we just for the crisis in long-term care?
Yes, in particular, yes. In those residences, yes.
Yes, thank you. So it is certainly a very unfortunate situation. I have every confidence that when individuals go and work in long-term care, their expectation, their need is to support residents. I think what is unfortunately happening, and you see some similarities in Ontario, is the inability to get the work done in this COVID environment. What COVID has taught us is that there are staffing issues. If you do not have the staff, then we cannot provide the right care to our residents or those that are living in the homes. If we do not have the funding, then we cannot train our staff to be prepared for a COVID pandemic such as what we've experienced. I do believe that through the province and through the federal government that there will be improvements, and this is a systemic issue. It is not an issue that has just risen today. It's a systemic issue. I believe that through the federal government that there should be a component of long-term care in as a national act, so that there is more oversight. And I have to say, I also believe that while we go in and improve the situation in an emergency, there is also long-term improvements that must be had. I'll go back to emotional care. It is not necessarily about making things more command and control through legislation, but ensuring that legislation also involves emotional care, a different type of expectation for our staff in long-term care, one that they too will thrive, one that staff will enjoy to come to work and support those residents they care for. So those are some of the things. It is about staffing, it is about funding, it is about getting the feds to support. But certainly it is long-standing and lots of work needs to be done. That is not, I'm going to say it again before I get close, it's not about the command and control. It is about how do we support our residents and our staff in an emotional-based culture.
Thank you, Mr. Desley.
Je vais vous entendre pour les quelques...
I'd like to hear you for the few seconds that are left. This recommendation...
Time is up.
Merci beaucoup, Monsieur le Président.
Thank you, Mr. Chair.
We go now to Ms. Kwan. Ms. Kwan, please go ahead, 2 minutes and a half.
Thank you. Ms. York, you mentioned that at the moment, even with the provincial government's initiative in providing housing for the homeless population in the community, is only really 5% of the population that's really provided support for. I know that the federal government has not provided any resources to the province to provide that housing. And in the province's purchase of the Comfort Inn to make permanent housing for the homeless population, there was no contribution from the federal government either. So to that end, in terms of the need here, the federal government used to be a real partner in 1993 prior to them pulling out of affordable housing. Do we need to go back to those days where the federal government actually engaged in real partnership with the provinces and territories to address the homelessness crisis?
Absolutely, I would say that is really essential. Definitely with the hotels, as I mentioned, it's about 5% of those in need, which includes those who are homeless and those who are really inadequately housed and poorly maintaining SROs that are not providing the opportunity for social distancing or sanitation. So certainly would be good to see a partnership with the federal government. There was some action from the province, certainly not enough and not done in really a way that really targets those most in need. There was an urging for the municipality for some efforts being made there. So there's very little, but federally, it seems like there is the potential and the opportunity to do a lot more. We see that in other cities as well. There's been more, for example, in the Peel region, we heard that it's about 50% there. So certainly we'd like to see more.
Thank you. Two other quick issues on safe supply. We have a health emergency with respect to overdose. We're now having some measures with respect to safe supply. Would it not be essential for this to be permanent and also to make this program available in other communities across the country? And last but not least, on the question around protective equipment, some of the agencies got protective equipment, others not so much. And I wonder if you can expand on the situation there and the need.
Sure. So regarding safe supply, absolutely. There's been calls for years for a safe supply as the overdose crisis began in 2016, 2017. As I mentioned, it's about 1,000 deaths now. So it's really horrifying crisis, and safe supply is a very essential way to address that. So we'd like to see that extended. There's been no notice or no confirmation that this will be a permanent program. It was implemented for the pandemic, and it might be pandemic specific. So certainly we'd like to see that made permanent. And as I mentioned, many aspects of the pandemic actually contributed to that overdose spike because of less use of overdose prevention sites and lockdowns in buildings where people are isolated and not able to be with a friend or use safely with a friend. So that safe supply is really, really essential and absolutely should be made permanent and extended into other cities, because we know these things, again, happen everywhere in BC and actually across the country. There are tent cities, there's homelessness, it's happening everywhere. And the overdose issue, it happens everywhere as well. And so safe supply is one very specific measure that will really do a lot to address that.
Thank you, Ms. Kwan. That brings round 3 to an end, and I would like to thank all the witnesses for sharing with us so much of your time today, and for your excellent information and recommendations. And thank you to the committee for your time as well. And with that, we are adjourned. Thank you.
Sorry, Mr. Chair, may I just ask for all the witnesses, because there's just so much valuable information and limited time to ask questions, if the witnesses have additional information that they can send to the committee, if they could do so to send to the clerk's office for our benefit?
We are adjourned, but I would certainly invite all the witnesses certainly to do that. If they have more information, please send them to the clerk, and they will be translated as necessary and distributed to the committee. So once again, thank you, everybody.
Thanks so much.
Thanks, everyone. Thank you.